Hi everyone, I'm going to talk to you about cardiotocography, which is a CTG. The objective of this tutorial is to guide you through and let you know the standard terminology that we use to interpret the CTG, guide you through a systematic way, and you need to classify it and categorize it accordingly, and the underlying causes and the pathophysiology of CTG abnormalities. By the end of the tutorial, you are expected to be able to achieve a competency in managing and interpreting the normal or abnormal CTG. And last but not least, documentation. Let's talk about the CTG machine first. We actually has two models in the labor ward, if you realize. One is FM20. FM20, it comes with a Toko transducer. The Toko transducer is where you're supposed to put it at the fundus of the uterus, and it can help to record the contraction, the frequency of the contraction, not the intensity of it. Whereas the ultrasound transducer is to detect the fetal heart. So you put the you apply the electric gel over the ultrasound transducer. As for internal CTG, we use the machine for FM30. It comes with an internal probe, and this is the connector. All right, and this probe is towards the fetal scalp. It is contraindicated in fetus that are at risk of bleeding, such as maternal thrombocytopenia or those who are known to have thrombophilia. And the other thing is, if let's say you have a patient with blood-borne infections such as HIV, so these are the patients that you're not supposed to insert an internal CTG. Let's talk you through the traces of the CTG. This piece of CTG paper is called CTG trace. You need to check the setting, whether it is 1 cm per minute or not. Otherwise, if the setting is incorrect, you are going to interpret the CTG wrongly. So what do we mean by 1 cm per minute? Meaning that on the CTG, with these two columns, is actually representing 1 cm. So 1 cm is equals to 1 minute. Okay, so if you look into this line to this line is actually 10 cm, so which is also 10 minutes. Okay, and if you look into the vertical chart, so the vertical part is the fetal heart rate activity, then you can see the numbers. So it's as low as 40 to 220. So outside of it, it can show on the CTG machine, but it will be outside of the, you cannot trace it properly. And you also need to look at this part, which is the Toko activity, where you can see the contraction. And if you look here, so these small rows, you can see this is 100, this is 110, this is 120, and each of these two rows is actually 10 beats per minute, and one is 5 beats per minute. So this is how you're supposed to count and how you're supposed to calculate and interpret your CTG. When you interpret the CTG, you need to look into Dr. C. Bravado. So always go back to the basic, always define the risk, see the contraction, you need to see the baseline heart rate, look at whether there's any acceleration, the variability of the fetal heart rate, whether there's any deceleration, and the overall picture of it. First, we go to define risk. You need to look into the maternal risk and the fetal risk, and also intrapartum. For the mother risk, you have to see whether mother has tachycardia, pyrexia, or any other medical condition, or things such as previous scar will put the mother in having a higher risk intrapartum. As for fetus, you need to want to know whether baby has a history of antepartum hemorrhage, whether baby is growth restricted or not, whether there is oligo or polyhydramnios, whether it's a preterm labor or a post-date pregnancy. And you would also want to know whether there is prolonged rupture of membrane. And these are the other causes, other risks that you will find in intrapartum. Then we proceed to contraction. A normal contraction in labor should be less or equals to 5 in 10, meaning that 5 in 10 is still considered as a normal, all right, within a 30 minutes window. When you have too much of contraction, we call it as tachysystole, which is more than 5, meaning that 6 in 10 and above. All right. So if you have hyperstimulation, meaning that the patient has contraction more than 5 in 10, when the patient is on oxytocin. So it was induced and stimulated, so it's called as hyperstimulation. How do you count the uterine contraction? As I told you earlier, from this bar to this bar, it is 10 minutes, and you can see there is these two peaks here, so there is 2 in 10 minutes, 2 contraction in 10 minutes time. Next is your baseline heart rate. Baseline heart rate is the mean level of most horizontal and less oscillatory fetal heart rate segment, and it is estimated over a period of 10 minutes. I will show you what I mean in a while. And the normal fetal heart rate baseline is 110 to 160. Tachycardia is when it is more than 160. Bradycardia is when it is less than 110. Tips for you is always palpate the maternal pulse to distinguish whether this is a maternal pulse or a fetal pulse. So you look at this CTG, you draw a line at the mean amplitude, then you will be able to see the baseline is around 130 beats per minute for this CTG. As for this CTG, you draw a line again as well, so you can see the main fetal heart rate is at 170. So this is abnormal. So what are the causes of tachycardia or fetal bradycardia? You need to look into whether the mother has tachycardia or mother has fever, chorioamnionitis, whether mother is dehydrated or mother is on beta agonist drugs, or the baby has fetal hypoxia or arrhythmia can also cause fetal tachycardia. Whereas for fetal bradycardia, you need to look into maternal drugs such as beta blockers or whether the baby has hypoxia or fetal arrhythmia. Okay. How about this CTG? You cannot read the baseline and you don't know where is the baseline, don't know how to interpret it. The tips is you compare with the previous traces. Alright, so this is how you compare. So you can see from here, you can tell the baseline is around 130. Alright, and then until here suddenly disappeared already. So you don't know where is the baseline. So the baseline probably is around here, 80 beats per minute. At the same time, you should check the maternal heart rate. If the maternal heart rate is around 80 beats per minute, then most probably this is actually a maternal heartbeat. But if let's say the maternal heartbeat is 100, then you know this fetal heart rate or this CTG heart rate picking up at 80 beats per minute is a fetal heart rate, is a fetal bradycardia. Apart from that, if you didn't know how to interpret, always seek for help. Alright. So acceleration is a transient increase in the fetal heart rate of 15 beats per minute or more and lasting 15 seconds or more, but the acceleration should be less than 10 minutes. If let's say it is more than 10 minutes, meaning that there is a shift of baseline already. And acceleration is actually a hallmark of fetal well-being, meaning that the baby is still good inside. Okay, again, that is the baseline that you can see, and then that is the projection of the fetal heart acceleration, all right, from the baseline. Next is variability. Variability is oscillation in fetal heart rate signal, average bandwidth amplitude of the signal in 1 minute segment. Very complicated, you don't understand what it means. Basically, it just means this. Again, you put a line at this small wave here, put a line at the maximum, and put a line at the minimum, and then you measure how many. So this is roughly around 15 beats per minute. So that is the variability of the CTG, which is 15 beats per minute. Okay, it indicates the integrity of an autonomic nervous system. Whereas if you look at this CTG, so that is the maximum part of it, this is the minimum part of it. You look at it, it is actually still less than 5 beats per minute. So this is a CTG of a reduced variability. So reduced variability is when your the variability is less than 5 beats per minute for more than 50 minutes. It indicates fetal hypoxia or either cerebral infection anomaly or CNS depression because of opioids. And when it is increased, it is also not normal. It may be seen in fetal hypoxia or acidosis. If your variability is more than 25 beats per minute for more than 25 minutes, then it is abnormal. Okay. So what is a sinusoidal pattern? So it has been described as a regular, smooth, undulating signal resembling a sine wave with an amplitude of 5 to 15 beats per minute with a frequency of 3 to 5 cycles per minute lasting for more than 30 minutes. It's a very long description, but what does it mean is basically it is a sine wave pattern. When you see a sine wave pattern, then you ask yourself, is the amplitude 5 to 15 beats per minute? Yes, it is within 5 to 15 beats per minute. And how is the frequency? Does it occur like 3 to 5 cycles per minute? Yes, this is 3 to 5 cycles per minute. So this is most likely a sinusoidal pattern. So it indicates a fetal anemia, which is abnormal. Okay. Next is deceleration. Probably the most confusing component in CTG interpretation. Deceleration is defined as a decrease in fetal heart rate below the baseline for more than 15 beats per minute, lasting more than 15 seconds. This is what we call as an early deceleration. It is shallow. Remember the words of symmetrical. It is symmetrical and it is short lasting, and it has normal variability within the deceleration, and it coincides with the contraction. Okay, this represents a fetal head compression and rarely associated with fetal hypoxia. Next, we have variable deceleration. With the name of variable means everything is varies in the size, in the shape, and in the relation to the contraction. And we further classify it into with or without consonant characteristic, which I'll talk to you in a while. And this usually is because of cord compression. Next is a more sinister one, is late deceleration, meaning that it occurs roughly around 20 seconds after the contraction, and it comes in a gradual onset. This is a sign of uteroplacenta insufficiency. If you see a late deceleration, you should be scared, all right? Last is the most sinister one, is a prolonged deceleration when the deceleration is more than 3 minutes. It is usually caused by acute events and it needs immediate intervention. Okay? So as I told you earlier, early deceleration is shallow, symmetrical, short lasting, and you have the normal variability. As you can see, it coincides with the contraction, and it actually looks symmetry, and it looks shallow and transient only. Okay? The presence of early deceleration in early labor, you cannot say that it is normal, because early labor, if you see this CTG in 2 cm, 1 cm, you do not expect the fetal head to be compressed. So something must be not right. So you need to seek for help. Okay. Next, I'll talk to you about late deceleration first. So this is what I mean. You have a contraction, then only you have the deceleration, and usually it looks like a U shape because it is wide. It will always lasting more than 1 minute. Okay, so this is abnormal, okay, indicating that it's chemoreceptor mediated response to hypoxemia, meaning that the baby most likely is hypoxia. The most complicated one will be variable deceleration. So it varies in size, shape, and relation to the uterine contraction, and it is because of umbilical cord compression with or without concerning characteristic. What does this with or without mean? So we talk about without concerning characteristic. There's nothing that you are concerned about this variable deceleration. So this is most likely non-sinister just because of cord compression types of variable deceleration, where you can see the V shape, okay? And these are the shouldering. So this is a V shape because it is abrupt and it recovers very fast. So it's seldom associated with serious fetal hypoxia or acidosis. So again, this arrow is the shouldering. Okay. But how about those variable deceleration that you are concerned? You have concern is when it lasts more than 60 seconds, it reduces variability within the deceleration, it cannot return to the baseline, it has this biphasic shape, or there is no shouldering. And this is commonly associated with fetal hypoxia or acidosis. Okay, let me talk you through about what is a biphasic. Biphasic means like a W sign, the W shape. When they have deceleration, then the baby is recovering. The baby haven't finished recovering, another deceleration come in. So this is called a biphasic. Next, you will have this U shape. U shape meaning that the contraction, the deceleration lasting more than 60 seconds. Okay. And if you realize there is no shouldering that you could see, so it is like flat over here. There's loss of shouldering. And what do we mean by failure to return to baseline? Okay, so you can see this is the baseline heart rate 160. Initially here, after deceleration, it go back up to the baseline 160. Here is also almost the same, but here it overshoot a bit. So as it progress, it become reduce deceleration, and then it go up and overshoot. So if as the CTG progress, you will see the baseline is like shifting towards higher end already. So it cannot return back to the previous baseline. This is what we call as a failure to return to the baseline. Okay. And this is a sign of autonomic dysfunction of the fetus, and it is a sign of fetal hypoxia. And what do we mean by loss of variability within the deceleration? You see there is still some variability here, but can you see it is like very smooth line inside here? This is what we call as a loss of variability within the deceleration. Okay, so all these features are concerning characteristic, means you are concerned. Which when you see this kind of deceleration, you are worried. Okay, and you are more worried about this prolonged deceleration when the deceleration is lasting more than 3 minutes now. Okay, so the acute causes that you need to ask yourself, is that a cord prolapse? Is it an abruption? Is there a vasa previa, or is there a uterine rupture? And you have to know what is a 3 minutes rule. If you see a deceleration more than 3 minutes already, first you call for help. Then you need to know whether this is a reversible or not reversible. You need to find out whether it is reversible or not. So if it is reversible, you try to correct it, and you should anticipate the recovery signs of recovery at 9 minutes. But if let's say it is an irreversible cause, for example, it is a cord prolapse, so there is no point for you to wait for recovery. Then you see if it is not os fully, you need to bring the patient to operating theatre immediately. Okay, then by 9 minutes you have to decide already, that's the max. Caesar or vaginal delivery immediately, and you need to prepare and go for delivery, expedite the delivery as soon as possible. Okay, by 12 minutes your baby should be on the way coming up already. Okay, so overall, how are you going to, after we have talked about baseline, Dr. C. Bravado, you define the risk already. So you see on this chart, you define the risk already. You have the contraction, then you have the baseline, variability, deceleration, acceleration. Then you need to give an overall impression. So overall impression, you need to tell, do you think this is a normal CTG or a suspicious CTG or a pathological CTG? And what is a reassuring, non-reassuring abnormal features? Okay. So first of all, you have already defined your risk factors. You fill up here, then your contraction, then you look into the baseline. So a reassuring features of a baseline is when it is 110 to 160. But if let's say it is 100 to 109 for more than 10 minutes, then it is non-reassuring. Or you have a fetal heart rate baseline of 170, so it falls in between this category, so it's also non-reassuring. But if let's say it is more than 180, it is abnormal. Okay, subsequently you need to look into the variability. Variability, if 5 to 25 is considered as normal, which is reassuring. But if let's say it is less than 5 for 30 to 50 minutes, then it is something fishy, so you put it as non-reassuring. Or if it is more than 25 for 15 to 25 minutes, then it is non-reassuring. But it became abnormal if you see the baseline variability is reduced for more than 50 minutes, or if it is increased 25 minutes. All right, or you see as sinusoidal, this is considered as abnormal. All right. Then next, you want to see deceleration. So many columns inside the deceleration. First, you ask yourself, is this a late deceleration? If this is a late deceleration, is it persistent or not? If it is persistent, is it less than 30 minutes or not? If it is less than 30 minutes, it is a non-reassuring. If it is more than 30 minutes, then it is something abnormal. Okay, this is for late deceleration. Then next, you also want to see whether this is there any acute bradycardia, or whether there is any prolonged deceleration. So if it is less than 3 minutes, straight away is an abnormal already. Okay, so the variable deceleration. Okay, I'll come back to this. All right, variable deceleration is a thing that always confuse everybody. Is always confused. For variable deceleration, you need to ask yourself these 3 questions. First, is there any concerning characteristic? Is this persistent? Persistent means that it lasts more than 50% of the contraction. And also, is the variable deceleration last more than 30 minutes or not? So if your answer is yes for everything, it is already an abnormal features. Okay, but if let's say when you ask yourself, is there any concerning characteristic? Yes, there is. Is it persistent? No, it is not. It is not persistent. Then if let's say it is more than 30 minutes, then you will say that it is actually a non-reassuring features. But if you ask yourself, is this a concerning characteristic? Yes. Is it persistent? Yes. Then you need to see. If it is less than 30 minutes, okay, this will be at the non-reassuring. But if let's say it is again, yes, it is more than 30 minutes, then it go back down to this one, abnormal features again. All right. So next is, if you did not see any concerning characteristic, then you ask yourself, is it more than 90 minutes? If it is less than 90 minutes, it's still considered under reassuring. But if it is more than 90 minutes, then it is considered non-reassuring. So this variable deceleration without concerning characteristic, all right? So it's supposed to be under non-reassuring. Now you have finished filling up these reassuring, non-reassuring, and abnormal features. Then you need to classify it into normal, suspicious, or pathological CTG. So for a normal CTG, okay, you have to have all reassuring, okay. But if let's say the patient is in labor, then if there is no acceleration, you still can, and other features are reassuring, then you will still say that it is a normal CTG. If you have one yellow color column, okay, but the rest is at the green color column, then it is considered as a suspicious, meaning that one non-reassuring, the other two are reassuring. But if you have one abnormal, one red color, or two yellow color, then it is actually a pathological CTG. Okay, so what does it mean? A normal means no fetal hypoxia or acidosis. A suspicious one, there's a low probability, but pathological one is a high probability of fetal hypoxia or fetal acidosis. This is what you should do. So for patient that who came in and you do a CTG, you need to interpret it with Dr. C. Bravado. Then after you have interpreted, you need to classify it into normal, suspicious, or pathological. So it's a normal one, then you can continue your routine monitoring. If it is suspicious for your level, you inform your MO, and then you will need to find out, is there any reversible cause? Whether there is hypotension, hyperstimulation, then you still have to continue the CTG monitoring. You need to document, and after you have identified the reversible cause, you need to do some conservative measures. Okay, then if let's say the CTG is persistent or non-reassuring or worsening of the CTG, then you proceed next and see whether you need to do a fetal blood sampling or expedite the delivery. Okay, for pathological, more or less the same actually, but the process has to be a bit faster, especially if let's say you have an acute event or fetal bradycardia. A decision has to be made at least at 9 minutes. You have to decide already how this baby should come out. All right, this is reversible causes that I talked to you earlier. So you need to look out what are the causes. First, whether is it because of frequent uterine contraction, whether there is hyperstimulation or not, whether you want to administer tocolysis, you need to stop the oxytocin or reduce oxytocin, or if let's say a prostate was inserted, then you need to insert or remove the prostaglandin. If let's say the patient is lying down flat on the back, then you would like to change the patient posture to reduce the aortic cover compression. Or if let's say there is transient compression, then you can change the mother position. And if the patient is hypotensive, especially after epidural, then you need to discuss with the anesthetist, and also you can give fixed bolus infusion. These are the conservative measures that you can take to correct. Then you monitor. So now we talk about two scenarios now. So first scenario, you have Mdm A, 30 years old, Primid, 40 weeks, 7 days, admitted for IL for postdale. Then she was sent to labor ward. She was 3 cm, ARM was done, and it's MMSL. So this is her CTG. So you need to interpret the CTG. First, again, Dr. C. Bravado, define risk. She's a Primid, she's postdale, she has MMSL, and this is an induction case. C, contraction is 2 in 10 contraction. Baseline is 130. Okay, and the variability is around 15 beats per minute, which is more than 5, and there's presence of acceleration, there's no deceleration. Overall, this is a normal CTG. Okay, so you continue observation. Okay, so this is how you're supposed to document. You have the stamp. There's a stamp for CTG interpretation in the labor ward and in the maternity ward. You are supposed to stamp it and comment it. Okay, so this is how you're supposed to be. Normal baseline, normal variability, there's no deceleration, and there's presence of acceleration. So this is a normal intrapartum CTG, and then you sign chop. Okay, so she was started with oxytocin 0.3 mils per hour and then titrated to 2.4 mils per hour. This is her CTG 3 hours after the oxytocin. So interpret the CTG. Again, you need to define the risk. She's a primid, postdale, MMSL, induction of labor, and now she's on oxytocin. Okay, so see, look at the contraction. So this is 10 minutes again. All right, so you count 1, 2, 3, 4, 5, 6. So it's 6 in 10. Okay, so contraction is 6 in 10. Then after that, you look at the baseline. So baseline is roughly here. It's around 165 beats per minute, fetal heart rate. So you also have to remember the previous fetal heart baseline is how much? It was around 130, right? So there is a change in the baseline. So it's also something that you need to take note. There is absence of acceleration. The variability, how is the variability? You can look at it, it is less than 5, but this is how many minutes tracing. This is around 10, 11, 12, 13, 15, 16, 17, 18 minutes tracing. Okay, you can still argue it is still less than 30 minutes. So let's see what happened next. Is there any deceleration? Yes, there is deceleration. So you may argue, every deceleration actually coincides with the contraction. So is this an early deceleration? Is a normal? So you have to look carefully. So this is not symmetrical. You can see this is not symmetrical, and this is actually a variable deceleration with concerning characteristic. Why do I say that there is concerning characteristic? It's because there is loss of shouldering. Okay, it's actually deep deceleration. And you can also see that it's reduced in the variability within the contraction, and most importantly, this is not symmetrical. Okay. So we have come to this as we have this primid, we have defined the risk. Contraction is 6 in 10. The baseline variability, baseline heart rate is at this non-reassuring column. There is no acceleration, doesn't mean that it must be abnormal, but never mind. Look at the variability is less than 5, but 18 minutes. You still cannot put it inside this yellow color, right? There's no place for you to put. Never mind, we go and continue with the deceleration. It's concerning characteristic, persistent, but it is less than 30 minutes, right? So there are two non-reassuring components already. So meaning that this is actually a pathological CTG already. Okay, but I will say I will put the variability at this because I am worried about the variability. So this is a pathological CTG. So what should you do? Okay, you should off the oxytocin. You look at the reversible cause. Yes, she is having 6 in 10. Most likely is because of the oxytocin is because of hyperstimulation. You off the oxytocin. You can left lateral her. You want to improve the aortocaval compression. You want to improve the perfusion to the uterus, and you have to inform your MO. You need to reassess the labor progress, meaning that you need to palpate the abdomen, you need to do a VE, and also you need to monitor the mother's vital sign. Probably you might need to tocilize her if the condition, the contraction is persist 6 in 10 and the CTG is abnormal, and you have to closely monitor the CTG. Okay, all right. Okay, so next we move to scenario 2. This is Madam B, 40 years old, G2, P1, 37 weeks, 1 previous scar, compare of leaking LIQUA for more than 24 hours. She has contraction pain, os is 5 cm, clear LIQUA. So this is a CTG when she comes. You need to interpret the CTG. Go back to baseline. Dr. C. Bravado again. So define the risk. What are the risks? Advanced maternal age, 1 previous scar, compare of leaking for more than 24 hours. Alright, those are the risks. Contraction. Look at the contraction, here to here is 10 minutes. So you see 1, 2, 3. Here is also 10 minutes, 1, 2, 3. So it's around 3 in 10. Contraction is 3 in 10. Then next we look into the baseline. So you see the baseline is around 140 beats per minute. Okay, then you look into the variability. Variability is a little bit tricky because here in front is like less than 5, but this is around 15 minutes tracing is less than 5, but subsequently behind here it is normal. You can see at the second part of it, it is more than 5, so I will still say generally this is more than 5 for the variability. Then next we look at the deceleration. What kind of deceleration is this? I will say this is a variable deceleration. You can see it is asymmetrical. Okay, so occasionally you have, occasionally you don't have. This one looks like a bit like a late deceleration. This one looks like late. This one looks coincide. So there is variety in the relation to the uterine contraction, and there is also concerning characteristic that I can see. It is also asymmetrical here, so it's a variability in the shape and the size as well. So this is a variable deceleration. Is there concerning characteristic? Yes, there is, because number one, there is no shouldering that you can see. Number two, you can see it is actually wide, more than 1 cm. Okay, all right, and some of the deceleration has reduced variability within. Okay, this one is also reduced variability within. So I would say that this is a variable deceleration with concerning characteristic, lasting for how long? 1, 2, 3, 4. This is easily a 45 minutes tracing. And whether it is persistent or not, at one glance, yes, it is persistent. How do you count? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So there are 14 contraction. How many deceleration? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So it's more than 50% of the contraction. So yes, it is there's concerning characteristic that it is persistent and it is more than 30 minutes. So this tells you that this is go into the abnormal features. Alright, concerning characteristic, persistent and more than 30 minutes. So it is a pathological CTG. So when we chart, okay, one thing I want to highlight to you earlier, you might saw a small acceleration, but generally it looks like it is a pathological CTG. So this is how it is. Baseline is normal, variability is normal, but there is one abnormal features. Okay, so it straight away fall down into pathological. All right, so what should you do? You should put her in left lateral. You should inform your MO. You can run her fluids if she is hypotensive or she is dehydrated. Remember, she has one previous scar. Is there any scar tenderness? If it persistent to be pathological after your conservative measures, then you have to consider fetal blood sampling or expedite the delivery. Okay? All right, with that, I thank you.